I also want to thank everybody for joining. I think it's wonderful for you guys to give up your time. I know it's almost dinner time with the lockdowns being lowered. So everybody that joins, very welcome. I think the reason for this webinar was to just put us into the picture of where we stand with prolapse surgery. And I think with the whole COVID issue and us not being able to do elective surgeries, we will get a number of patients coming back now into the system in the next couple of months that wants elective surgeries. So I think it's a good time to talk about the current thinking about prolapse surgery. And obviously this is such a big topic that we're not going to go through everything. So we've decided to break it down in a few topics, and we're going to start off with the anatomy, just to refresh the anatomy a little bit. And I must say, I think it's a little bit boring if we talk about the same issues every time, but with anatomy and pelvic organ prolapse, I think it's so relevant that if we just understand the anatomy and just think about that again, it makes the decision making for the different operations so much easier. So I'm just going to go through a few important things that I think that we have to think about if we operate on prolapse patients. The first thing is just the tissue structure of the vaginal wall. Remember that this is a healthy, thick epithelium with a connective tissue layer as well as a muscular layer, and that keeps the vagina tight and firm, as well as the muscles surrounding it in the pelvis. And we often find patients who has got atrophic tissues and severe prolapse, and this is one of the reasons why the surgery for vaginal surgery for prolapse is sometimes difficult, and why we sometimes get erosions and scar tissue formation due to the structure. So remember to give topical estrogens if there's severe atrophy to rebuild the layers of the vaginal epithelium. Now, just a little bit on the pelvic floor structures. It is important to remember that the muscular layer is the layer where the fascia will attach to, and the tendinous arc, which is the white line that you can see on the obturator muscle there, attaches the fascia that supports both the anterior part of the bladder up to the cervix in the anterior compartment. And then surrounding the cervix, there is condensation of that fascia in the cardinal ligaments as well as the sacro-uterine ligaments. So if we just look at this picture, if you have a good fascia with good attachments both on the lateral and the apical part, then we will have good support of the anterior vaginal wall, and that is what we would like to achieve in surgery. Now, this is a very complicated picture, but I just put this in for us to understand that this is a three-dimensional structure that we have to reconstruct. So if we do pelvic organ prolapse, especially in the more advanced prolapse cases, it is very important to understand the three-dimensional structure of the pelvis. And if we look here and you see the rectum at the back, the vagina cut open with the urethra, and then the sacrospinous ligament stretching from spine to the sacrum, which we often use as a support structure that you can hitch up the vaginal vault to. So this is just a more simplified picture of the different fascial supportive systems. So again, the lateral bony structures with the muscles attached to that, with the levator running behind the rectum, and then the fascial layers with the condensation that attaches to the white line, anterior the vesicovaginal fascia that supports the bladder, and posterior the rectovaginal fascia that supports the rectum. And if you keep this picture in your mind, if we do our dissections, it's so much easier to understand what's going on in the reconstruction of the different fascial layers. Now, remember that if you operate pelvic organ prolapse, it is important to understand what functional abnormalities we will get. And if you divide it into 3 compartments, the front compartment is the pubourethral ligaments and the external urethral ligaments, which is not that strong, as well as the support of the urethra anteriorly, and that will lead to stress incontinence if there is not good support. And we know from the work of Professor Petros and Ormston that the support of the urethra is actually more important than the concept of the bladder neck suspension that we used to do with Birch-Copper suspensions. The middle ligaments are the white line, which is the arcus tendineus, fascia pelvis, and the cardinal ligaments. And that will hold the cystocele high up so that you can get good emptying, and that will prevent frequency and urgency or overactive bladder symptoms. And the back ligaments are those that will support the rectocele or the rectum, and those are the uterosacral ligaments as well as the perineal body. So if you look at this graphic, you can just see that the blue is the vagina with the pubourethral ligaments and stretching back all the way to the uterosacral ligaments that keeps the vagina and the organs in place. Remember that to control the feces is important. The puborectalis will swing around the rectum and lift up the rectum to help with continence. And that has to relax as you strain down, and then it straightens the urethra and it straightens the anorectal angle, and that will lead to good evacuation. So if there's not good functional support of the rectum, it can lead either to obstructive defecation symptoms or it can lead to fecal incontinence. So how do we replace these attachments? The pubourethral ligaments, we know that we replace anteriorly, but in the posterior compartment, we do strengthen the perineal body, and that can be done with a tissue repair, and we can replace the uterosacral ligaments with a small sling of mesh that we anchor to the sacrospinous ligaments, and we'll talk a little bit more about that if we talk about the technique. So just one important thing to emphasize underneath the restructuring of the pelvic floor is, remember the perineal body is a very important structure to support the outlet of the pelvic floor or the vagina. And we'll say a little bit more about that if we talk about this, the quantifying system of prolapse. But we often find that there's, if you examine the patient, there's ballooning of the perineum, which means that the perineal body is defect. So sometimes the introitus doesn't look that wide, but if the patient strains down, you see this excessive ballooning of the pelvic, of the perineum, and you know then there's a defect in the perineal body. And we know that it helps a lot if we repair the perineal body at the end of the operation. So if you do a posterior compartment plication, you must always do the perineal body, and be careful not to narrow the introitus, but to build up the perineum, and that is technically a very important part of your operation. So just a comment on the integral theory that Professor Petros actually describes so well in functional abnormalities of the pelvic floor, both in overactive bladder symptoms, stress incontinence, as well as fecal incontinence and obstructive defecation symptoms. The traction needs to be, you need to have good support on the pubourethral ligaments, and then the traction is upwards and backwards to lengthen out the fascial support, and that will flatten the part underneath the bladder and the rectum to give good emptying of the bladder and good evacuation of the rectum. So what type of abnormalities do we find in the pelvic floor? So again, this is a little bit complicated picture. So I just want you to concentrate on the anterior zone where there's damage. So this is the part that's anterior to the blue line. And those are mostly the pubourethral ligaments and the external urethral ligament. And that will lead to stress incontinence. And if you take the part, the middle zone that's anteriorly on the picture, anterior to the symphysis, you get a support of the pubocervical fascia, which are attached to the cardinal ligaments and the arcus tendinous fascia pelvis. And if you damage this zone, that will lead to overactive bladder symptoms or incomplete bladder emptying. And then the posterior part, posterior to the purple line, shows you the uterosacral ligaments, the rectovaginal fascia, and the perineal body, which are the structures that you have to see to that it's well supported if you want to do a good functional reconstruction of the posterior compartment. So anteriorly, the pubourethral ligaments, middle compartment, the fascia, as well as the cardinal ligaments, and the white line, and posterior, the uterosacral ligaments, as well as the rectovaginal fascia and the perineal body. I'm not going to go into a lot of detail about the classification systems. The Baden system is the one that was previously used quite widely. We now use the POC-Q classification system, and the reason for that it better describes the different compartments of the pelvic floor. So the Barden-Walker system takes the grading up to the hymenal ring, and that is grade 1 and 2, that's still inside the hymenal ring, and grade 3 and 4 outside of that. But it doesn't describe the different compartments as well. So this is just a picture of a simple cystocele. And I saw one of a typical patient this afternoon that looked like this. It's actually one of the nice operations to do, because the patient will complain of the bulge and maybe a little bit of incomplete bladder emptying, but the uterus is still in a good position. The posterior compartment looks good, so the repair will just concentrate onto the anterior compartment. So this is just a variety of stage 1 to stage 3 anterior prolapse with or without a uterus in situ. And I'm not going to go into the POC-Q system, because I think that's a thing that if you want to use it, you can easily just get it from the literature. The important thing about the POC-Q is that it measures the anterior and the posterior compartment, the walls of the anterior and the posterior compartment, as well as the genital hiatus and the perineal body. The things that we don't measure with the POC-Q that I would recommend for you just to make a note about is to note hypermobility of the urethra, as well as a defect in the perineal body. As I said earlier, the ballooning of the perineum, because we take the genital hiatus as a measurement of support of the perineal body, but that's not always a good indication that there's a good perineal body. So always look at the ballooning and do a rectal examination where you lift the anterior rectal wall into the vagina and feel for the perineal body. That's one thing that's not described if you do a POC-Q examination. So this is a picture of a simple rectocele. The important things to see here is that the bladder and the uterus is in a good position, and we can see that the rectovaginal fascia is stretched, as well as the rectum is widened. So the rectal lumen is widened, and because of that, it pushes the anal canal a little bit posteriorly. And if you now look at the recto-anal junction, you will see that it increases that angle, and that's why we often find that this gives obstructive defecation symptoms if you don't fix this. So the apical prolapse, here we see the uterus coming down, the cervix outside the introitus, and it pulls down, it gives a traction cisterna rectocele. The rectum is not dilated, but it actually pulls the bladder and the rectum down with it. But as soon as you push the uterus back up, the fascia layers are not really stretched out, so you don't have to fix them much. Neither do you have to narrow the lumen of the rectum, because it's all a traction defect that you have. Mostly we will have a combination of an apical descent as well as an anterior and a posterior descent, especially for the grade 3 and 4. It's mostly a combination of all compartments. So sometimes if you do an examination or you hear the patient's symptoms of a bulge, it's different structures that's implicated. So how can we differentiate between something that looks like a cystocele, but the underlying abnormality is actually different? So this is a cystocele. Now the problem with this is that it might be a midline rupture of the vesicovaginal fascia that you can see on the top right-hand picture, or it can be a lateral tearing of the vesicovaginal fascia off the lateral side wall of the pelvis. And that's two different pathologies, but it presents as the same disease. So you will say that the patient has got a grade 3 cystocele, but it might be a lateral defect or it might be a midline defect, and sometimes it's a combination of the two. So here we see some more pictures of the same of the same defects. The normal one on the first two pictures, you see the vagina there with good support of the bladder. And if you look on the graphic picture just below that, you see the triangular purple structure is the fascia that's supported from side wall to side wall up to the cardinal ligaments that holds up the whole bladder base. And if that is in position, as we said earlier with the integral theory, that will stretch out that fascia and it will prevent overactivity of the bladder or incomplete emptying. In the middle pictures, there is a midline defect. You clearly see the bulge, and mostly if you look clinically, it'll give a balloon-like stretched out vaginal skin appearance. And you can see in the middle bottom picture that the fascia is actually torn open in the midline, and the cystocele pushes through there. On the right-hand side picture, you'll see on the top picture there is a lateral defect. So the lateral sulcus there is completely torn off and comes down. So the vesicovaginal fascia is torn off the white line, and on the left-hand side of that specific patient, you can still see the lateral sulcus, so it's still attached to the side wall there. And if you look at the picture on the bottom right-hand side, you will see that the whole triangular purple fascia comes down as a unit, and the cystocele will lie on top of that. So this is what you see as a cystocele. The underlying pathologies can be quite different. This is just a picture to show a medial defect of the fascia. So at the back, on the left-hand side picture on your screen, you will see the white midline defect of the fascia. You see the ligaments that's yellow, that's attached to the sacrum as well as to the symphysis, and the white line is the orange structures where it's attached to the lateral side wall. The apical defect is also in the midline, but it's closer to the cardinal or the uterosacral ligaments, but you can see the defect there. And then on the right-hand picture on your screen, you can see the white defect is on the lateral side wall where it's detached from the white line, and that will give a lateral or a paravaginal defect. So if you have different structures that's implicated, because if the ligaments is not supporting the uterus or the cervix, it'll pull down the fascia and it would look like a complex problem, but mostly then the fascias are still intact. And once you replace the apex, you just have to see whether there's other defects that you have to repair at the same time. But it's not always the case. But in the severe, the grade 3 and 4s, in the majority of cases, we have multiple defects. So how can we get better with our diagnostics? The first thing is the physical examination. Just remember that what you see in a cystocele, it might be different pathologies underlying that. But if there's a cystocele with a smooth balloon-like appearance and the lateral sulcus are still intact, you can say that it's probably a central defect of the fascia. And if you have the lateral walls coming down and there's still rugae on the anterior vaginal wall, you can say it's more of a lateral defect. Remember, it's always important to feel for anatomical defects. And the one thing that we feel for in the anterior compartment mostly is the puborectalis muscle. So you feel on the lateral side wall, and the patient, if she squeezes or contracts her pelvic muscles, you can feel that the puborectalis is weak on the one side, and those patients has got a higher risk of recurrence if you do a repair. And then if you want to do the POPQ, remember the measurements are important, as in vaginal length and genital hiatus measurements. One thing that has become almost standard in pelvic floor evaluation is transperineal ultrasound images. And the reason for that, it is widely available. It's a very easy examination to do. The patient doesn't feel uncomfortable with it, and you can see in 2 or 3 dimensional planes, and you can do it real time, so you can have the patient straining down and contracting and look at all the different aspects. And I just want you to have a look at the picture on the right-hand side. You look with your ultrasound from the bottom upwards, and it's a sagittal view of the structures. The symphysis is on the right-hand side of your picture there. The urethra and the bladder is just underneath that. The vagina is just underneath that, and then you can see the rectum and the anus. And the one structure that's not marked on this picture is the levator, or the puborectalis muscle, that's just behind the rectum. And if you look in this picture, you can see that you can examine all of the organs of the pelvis by looking through the perineum, and you can do that as a dynamic test. So MRIs are done with a straining. It's fairly expensive, and we only do that in the complicated cases. And here we have 2 nice pictures of a cystocele on the left-hand side, rectocele on the right-hand side. You can see the cystocele is the green one that comes down below the line that was drawn from the lower edge of the symphysis to the sacrum, and it comes all the way down below the line, the skip line. And on the right-hand picture, you can see the red of the rectum coming down, and again you can see how distended the rectum is, where it forms the rectocele, and that causes the obstructive defecation. So now we get to the treatment. How do we repair these different structural abnormalities and what operations do we like to do for each patient. And I put the slide in just to show how complicated it can get. And I don't want you guys that don't do pelvic floor surgery often, and you do a sling or an anterior repair or a posterior repair, to be able to do all these different procedures. But I think it is important to know which procedure in the anterior and which in the posterior compartment, and which apical support will work the best in your hands. So remember, there are obliterative procedures where we can just close the vagina or do a carpoclasis, and I don't want to go into too much detail for that. It's not a procedure that we do often. Just a few technical aspects on the anterior compartment repair. If we do a native tissue repair, we mostly repair the fascial layer between the bladder neck and the cervix. So if the urethra is in a good position, so the pubourethral ligaments are well supported, and the vault of the vagina or the cervix is in a good position, then it's a fascial defect. And as we showed in the anatomical slides, the fascial defect might be central, which might be in the midline or closer to the apex, or it might be a lateral defect. And what we normally do is we correct the fascial defect. And if you want to correct a fascial defect, it's very important to make your dissection such that you can identify the fascial defect. And one way to do that is to get your hydrodistension, the volume that you inject, right for you. So some surgeons will inject a lot of fluid to hydrodistend, but then it's sometimes not that easy to see the defect in the fascia. So I don't like to use too much fluid in the anterior compartment. And if I do my dissection, I try to stay on the same plane for the whole anterior dissection, so I can clearly see where the defect is and try and fix that. On the left-hand side of your picture, you see 3, A, B, and C, where the first picture is to show how far the bladder comes down below the urethra. And the second picture is where the fascial repair is done. And the third, C, is where the vaginal skin is closed on the inside. And here we just see a little bit more graphic pictures of those. This is when we do a paravaginal defect. So if there's a lateral defect of the fascia and you want to reattach that to the arcus tendineus, then you have to put stitches on the side wall, and those stitches are not that easy to get in. And you have to make sure that you pull it all the way up to the white line. It can also be done laparoscopically to close the paravaginal defect, but it is not an operation that we often do. If there's a lateral and a central defect, which is recurrence, we will mostly use a mesh to support the bladder from side wall to side wall again. So this is just a picture to show the central defect. So if you open up and you can see there's a clear tear in the midline of the vesicovaginal fascia. The ligaments, the yellow, are still intact. The lateral attachments to the arcus tendineus is still intact. Then you just repair the fascial defect. here you can see there's an apical defect, but it's also in the midline. Your ligaments are intact, the lateral attachments are intact, and then you just repair the fascial defect. In the majority of cases, we will transversely plicate the fascia because mostly you can't see these defects so well, and then you will just plicate the whole fascia to lift up the bladder base. But all of you that has done cystoscopies after you've done a latent tissue repair always see a bulge of tissue inside the bladder, and it's sometimes not that easy to catheterize the ureters because you lift up the whole bladder base. But if you rescope them in 6 weeks' time, it looks a lot better. If you place mesh, it looks a lot better because you flatten out the bladder base and you attach the forearms that will support the whole fascial defect that there was. So we'll say a little bit more on when we use mesh just a little bit later. So in the posterior compartment, here we can see on the left-hand pictures again, the rectocele, which shows the dilated rectum, and in the middle picture, the fascial, the rectovaginal fascia is repaired. There's a midline repair, or it's a transverse plication of the fascia so that it supports the rectum again, and then the skin is closed above it. And remember, in the majority of cases, we'll do a perineal repair with that. The right-hand picture shows how to do a perineal repair after you've repaired your rectovaginal septum or the rectovaginal fascia. So this again is a picture of the fascial repair, the site-specific repair. And I know Laurie and the guys that works with me often will know that sometimes it's easy to identify these defects and you can repair them. Sometimes if you repair the ligaments again, it actually demonstrates the fascial defects very nicely, and you can reattach them to the apex. But in this picture here, the ligaments are intact, and you can just see that there's a fascial defect that was closed, and that is what we call a site-specific repair. So I'm just going to say a few words on how to support the apex. Now, this is a splinter, which is a small or short piece of mesh that only covers the apex or the intracele. We don't use it for the rectocele, we just use it for a good support of the apex. And here you can see on the left-hand side picture, it's attached both sides to the sacrospinous ligament, and it lies just above the vagina and on top of the rectum. And we attach the vaginal wall onto that, or if there's an intracele, we attach the intracele just above the splinters. And the reason why I do a splinters is because sometimes the vaginal length is 8 centimeters or less, and then it's very difficult to do a sacrospinous fixation like a Richter's repair. And sometimes if the vagina is not that wide, with the sacrospinous ligament fixation, you pull the vagina to the one side. And if you use the splinters, you attach it both sides, and you almost create a new uterosacral ligament. And you can attach then the vault of the vagina or the cervix to that. Now, I must say, this is a technique that I definitely use more to get a good apical support in cases where we don't do sacrocarpopections. So this is sacrospinous fixation, ligament fixation. This is a thing that's often done, and there's an Ancoris system which doesn't have mesh, but only the suture material that you push into the ligament. And then you attach that to the vaginal vault and you pull it all the way up to the ligament. Remember that behind the ligament, there's quite a lot of vascular and nerve structures that you can damage. So there's a safe zone just 1.5 to 2 centimeters medial from the ischial spine, where you can put your little hook in, where the suture will come out, and you can then attach the vaginal vault to that. The dissection of the ligament is not always easy, so make sure that you open up the ligament properly, that you can make sure that your position where you place this, either with a capio suture or Digitech system, or one of these Ancoris systems, that you place it exactly in the right spot. Otherwise, you might get pudendal pain afterwards, or you might get significant leg pain due to bleeding or trauma of the lumbosacral plexus at the back of the ligament. So I just want to highlight a few things on the mesh. There was an article that sorry. Sorry about this. There was an article that Paul showed me, that was in the International Urogynecology Journal this year, and they looked at all the aspects of the mesh repair, and we know the FDA and the safety reports. And the interesting thing is the manufacturers are sued in 99.4% of cases. So only 0.6% of cases the doctor itself is sued for the complications of mesh. And the reason for that is easier to get a class action, and the manufacturers have to pay because they did not inform the doctors or the public on the complications of their product. And we know that there was a quick uptake and a wide use of the meshes, and it was not the right mesh, and it was a big mesh. So there was definitely an overuse of meshes in prolapse surgery. But most of the warnings from the FDA still is on the older meshes, not the newer ones that we use nowadays. So the next thing that I want to say is about the PROSPECT study. That's the one study from the UK that is always quoted to say that you don't need to use mesh. But we must remember, this was a multi-centered trial. It was mostly low-volume surgeons. Some of the surgeons has done 10 to 20 prolapse operations before they were enrolled in the study. They operated all comers from 2 to 4 prolapse, so it was not only complicated cases. And some of the centers operated less than 6 patients a year, which is not good for surgeons that would operate with the more complicated cases. And in that study, it showed that the recurrence might be a little bit higher in the native tissue repairs, but the symptoms in the two groups were exactly the same. And the complication rate in the mesh repairs were higher. So if we look at this study, it looks like there's no reason why you should use mesh, but I just want to highlight the fact that it is low volume surgeons, and it was not done for the indications that we use for mesh repairs. So in Asia, they can use self-cut meshes as well as kits, and it varies a lot from country to country. In Japan, they don't have any mesh kits available, but they use quite a lot of self-cut meshes that they attach with sutures. In South America and Africa, we know that we can still use kits, so it is still used. But the interesting thing in this article from Germany and Austria as well as Switzerland, a meta-analysis shows that native tissue repair in the complicated cases has got a 3 times higher recurrence rate. But they've got a system in Germany where only level 3 surgeons can perform mesh placements. And it might be one thing that we can consider in South Africa is that we must restrict the surgeons that do mesh repairs to those who do more higher volumes of prolapse surgeries. And in the future, the numbers of prolapse surgery will increase because the communities are getting older, and it is important for us to have the right indication and to do the right technique. So what do I use for indications for mesh? I use it in repeat surgeries, especially if the patient has been done by a doctor that I know that will do a good repair. I do it for grade 3 or grade 4s. I do it if I need a good apical support. I use it if there's a big or large genital hiatus, and we spoke about ballooning earlier. If there's puborectalis avulsion, and other cases if there's a high risk of recurrence for chronic cough, collagen deficiency, and increased intra-abdominal pressure, as in obesity. In incomplete emptying of the bladder, it sometimes helps to place a mesh because that will definitely help for the emptying. And remember, we use mesh mostly in the anterior compartment and for apical repair, but not for posterior rectocele anymore. So this is just a sacrospinous ligament fixation, and we're not going to say too much about that. This is a typical Richter repair that you can do either unilateral or bilateral with or without the uterus. And remember that bilateral plications will give a higher risk of constipation, especially if the vaginal the vagina is not wide enough. So this is the apical support with a sacrospinous ligament fixation and a small piece of mesh, as we described with a splinters repair, which I think is a good repair with very little mesh that you use. Remember that the sacrocolpopection, which is the abdominal placement of the mesh, is a very good operation and currently the gold standard for apical repairs. And it is a operation that if you do it well, there's not a lot of complications, but it is not a operation that everybody can do every now and then. So make sure that you get good training and you do it properly. So what are the advantages of a vaginal repair? There's obviously no incision. You can have direct access to all the compartments. You can also do a mid-urethral sling procedure easily. With a laparotomy, it's easier to feel and to have your tactile senses. And with laparoscopy, the visualization is better. You have a small incision, shorter stay, less pain, and a faster recovery and less blood loss. The disadvantages of the vaginal repair is that you can't see so well. It's a small space, both for the team and the surgeon. Laparotomy is a longer stay and more pain, and a little bit higher morbidity. Laparoscopy is the increased costs and increased learning curve that can lead to complications. So just a short picture on the products that Promedon has that I use. Remember, the POPQ stage 1 and POPQ stage 2 is still for conservative therapy, pelvic floor training and physiotherapy. Stage 2 to stage 3 and 4 become increasingly a surgical issue, and you can use the native tissue repairs, or you can use the Anchorus, which is a meshless apical fixation system, or the splinters. And if there's severe anterior compartment prolapse, you can use the Colostar S, which is the anterior mesh that supports the whole bladder base. I don't use the Colostar P, but I know there are some guys that would use that. And as you can see here, it's only used for the recurrence prolapse and for the higher grade prolapses, not for the primary prolapse. So just what are the points to consider for the right treatment choice? Again, age, what the patient do for a life, whether she's menopausal, whether it's a primary or a recurrence operation, what the BMI is, whether there are specific birth defects that you want to rectify, whether the patient has got chronic cough, and then depending on whether the patient has had a hysterectomy, whether you want to preserve the uterus. So just the last two slides, and then we can have some questions if there are any. This is a patient of 45 years of age. She's pre-menopausal. She has a primary repair. She's got a stage 2 anterior prolapse with a midline defect of the vesicovaginal fascia and no other comorbidities. And I think the majority of us will have no hesitation if this is a bothersome symptom for her. She feels the bulge and she has got incomplete bladder emptying, to do a site-specific fascial repair of the anterior compartment, and that's all you need to do if the apex is in a good position. The second case is a 71-year-old who is postmenopausal. She's had a native tissue repair 4 years before. Her BMI is 28. She had 3 children, and she's got high blood pressure. She had a laparoscopic hysterectomy. And the POPQ staging is a unilateral paravaginal defect, an apical stage 3 prolapse, and posteriorly stage 1 prolapse. So if you look at the anatomy of a prolapse, stage 2 and 3 in the anterior compartment, stage 3 in the apex, and stage 1 in the posterior compartment, then you can think that because she's got a significant apical defect, you can do a laparoscopic sacrocolpopection, but you can also do a anterior repair with a splinters and a native tissue repair of the anterior compartment, and I would normally do a perineal body repair with this case. So these are two cases where you can decide which is the best treatment to do on a specific complicated prolapse case. So that is just the different aspects that I wanted to share with you. I think it's important for us to be good at the repair that we do, to know the different defects and to do the right thing. So if there are any questions or any comments, I would love to.
I'm going to unmute everybody. I'm going to unmute everybody now, and then you're welcome to ask questions. And while I do that, I just want to say thank you, Dr. Van Wijk, for a really great presentation. And thank you to everybody for taking the time to attend this webinar tonight. I think we're very blessed and very pleased because we've had 57 attendees on this webinar tonight, which is fantastic.